Hi everyone, it's Derek here from IDoMed. In today's video, we'll take a look at irritable bowel syndrome, IBS. It's quite a common condition that can affect up to 20% of the general population. However, this figure may be underestimated because many people do not seek medical attention for their symptoms. We'll take a look at how we assess and how we manage these patients. Now, IBS typically affects our patients between the ages of 20 and 39, and because it's a functional disease, we might see it relapse and remit over time. The underlying pathophysiology is poorly understood, but what we do understand is that there's a problem with the gut-brain axis, which leads to issues with the central nervous system signals and therefore results in the symptoms that we see. To make a diagnosis, you need to firstly suspect IBS based on the symptoms, then you need to exclude alternative diagnoses. So IBS is suspected when our patients present with the following symptoms for at least 6 months. Abdominal pain and discomfort may be seen, and this may also be worsened by eating, but also may be relieved by opening the bowels. Bowel frequency may be increased or reduced, and also patients may complain about passing mucus within their stools. So current guidance highlights the importance of being really cautious about making this diagnosis in our patients over the age of 50. Now, the way in which we approach it is by excluding more sinister or severe conditions that might mask or cause similar symptoms. So the main ones that we need to be aware of and to exclude include the following: inflammatory bowel disease, celiac disease, ovarian cancer, and bowel cancer, in which we should have a low threshold of doing a fit test if there are any symptoms which could be consistent with a diagnosis of bowel cancer. So as I've mentioned before, our approach to investigating this condition is really by ruling out more sinister or severe causes. So current guidance suggests thinking about blood tests, which may include an FBC, CRP, ESR or plasma viscosity, as well as our celiac serology. Now, with our patients that may be under the age of 45 that present with diarrhea, we also need to think about arranging a faecalcalprotectin. We also have to have a very low threshold for arranging a fit test with certain patients that present with similar symptoms. In addition to this, in our patients, especially women that are aged 50 or older that present with abdominal pain or bloating, we might need to think about arranging a CA125. So our management here is via an individual, personalized, patient-centered approach. So like always, we discuss with patients making certain lifestyle modifications, such as adjusting the exercise levels and looking into their diet. All patients should also look to identify certain triggers that might worsen their symptoms. If patients present with diarrhea as a predominant symptom, we need to advise them to reduce the intake of insoluble fibers such as brown rice and whole wheat pasta. We also need to advise patients to avoid fizzy drinks and also reduce alcohol intake, as these may all worsen their symptoms. Now, if patients present to us with constipation as a predominant symptom, we need to advise them to increase their intake of soluble fibers such as oats. Moving on and thinking about follow-up, we need to then follow up our patients in 2 months' time to see if any of these changes have made an improvement in their symptoms. At this follow-up appointment, we can then consider referring onwards to a dietitian if dietary changes have not helped. The dietitian can give a lot of advice about certain avoidance diets. We should consider prescribing a laxative if constipation persists. Now, if constipation still exists for 3 months, despite maximum treatment, NICE guidance suggests considering linaclotide as a next step, but this medication is usually a secondary care decision and is usually following onwards referral to secondary care. Now, if diarrhea is persistent, we could consider loperamide and then we adjust the dose accordingly. If abdominal pain and cramping still continues despite our best efforts, we can then consider our antispasmodic medication. These include mebeverine, alverine or peppermint oil. Then we review the patient. If there's still been no benefit, second line we can consider off-label use of our tricyclic antidepressants such as amitriptyline, and we can then review the patient and up-titrate it according to the response. And if this still doesn't work, we can then think about our SSRIs, so these can be included such as escitalopram, and then we can take it from there. Psychological therapies can also be considered to augment and add to our available treatments. So thanks a lot for watching today's video. We've taken a look at IBS, how we assess and how we manage our patients. As always, if you found it helpful, do not forget to leave a like and subscribe. Also, make sure you check out our gastroenterology playlist for more videos within this topic area. Until the next time, I'll see you soon.